All right. Good morning and welcome to Friday Chalk Talk. Today, I have the pleasure of introducing our guest, Dr. Patty Fogelman. Patty is the System Medical Director for Palliative Medicine at Guthrie Clinics, a rural healthcare system in northern Pennsylvania and southern New York. Her background, pertinent to today's topic, is that she launched the nation's first pulmonary palliative clinic for advanced lung disease management. And she's well known in our field with numerous publications and a passion for education. And that passion, no doubt, played a role in connecting Patty and CAPC and us. So our format for today is going to be a presentation to start, and we'll follow with a little bit of time at the end for some discussion and some questions. So Patty, thank you for being here with us this morning, and I will hand the mic over to you.
Great. Thank you, everyone, for joining us this morning and for letting me spend some time with you. We're going to talk today about a topic near and dear to my heart. My background, where I first came into healthcare all those years ago, was pulmonary critical care medicine, and then which I did for about 24 years. And then in the last 14 years of that, I started doing palliative medicine as well. And now for about the last 2.5 years, I've been purely palliative here at Guthrie. So anything pertaining to advanced lung disease patients is near and dear to my heart. So this talk was developed, really in an effort to kind of share the awareness for pulmonary rehab, how to help lung cancer patients, what are the different ways that we can engage palliative medicine interventions for these folks. So I hope that some of that passion and enthusiasm convey. There we go. So the agenda for today is listed on the screen. Really, we're just hoping to talk about how integration of pulmonary rehabilitation as part of the routine care we provide for lung cancer patients can improve their quality of life, both for themselves as well as the caregivers, because obviously when our patients have an improved quality of life, that's reduced caregiver burden and reduced caregiver strain. It helps them manage their symptoms and side effects. Breathlessness is improved, functional tolerance and exercise performance are improved, so their ECOG status will also improve. You also see a reduction in hospitalizations, readmissions, and you can really see how that can help their recovery as well, and they may be able to better tolerate therapies. I also have some resources at the end to kind of help anyone who wants to learn more about pulmonary rehab or lung care, and then of course time for some questions and discussions. So the first step is always like, why is this important? And we kind of alluded to that at the beginning. And it's really caring for lung cancer patients is way more than tumor eradication. And I think we can generalize that to the care of all cancer patients. That care of a cancer patient is much, much more simply than tumor eradication. There's close collaboration between us and oncology that I think helps us address their symptom management and their quality of life issues. Most of the time, the symptom we may be managing are things like pain or nausea and vomiting. But with pulmonary patients in particular, the lung cancer patients, you can really see a lot of dyspnea. You tend to see a lot of anxiety. Those two can go hand in hand, because when we're short of breath, we're anxious. When we're anxious, we get short of breath. When you have a tumor going on, then you may be more short of breath from that as well. And so then there's this cumulative effect that kind of just adds to their distress. So we kind of work in partnership with oncology to say, okay, you guys address the tumor, you guys do the cancer-directed tumor management piece of it. We're going to go ahead and address these other quality of life issues, all through the stages of lung cancer. And so when you think of why is palliative care important for these patients, their quality of life is affected by their cancer, no doubt. Treating those symptoms that they have reduces the effects of the stress they feel from their cancer. And I think that it really demonstrates that it's just as important as treating the cancer, because you don't want people to go through a line of therapy and just feel like they suffered or they struggled, or then they're questioning at times, was this even worth it because I've suffered so much, or I am suffering so much. And then this points to really where early integration of palliative care for these patients can provide improved outcomes and an improved quality of life. So I listed kind of in bullet points the benefits of palliative care, which I kind of feel like I'm talking to my tribe here. So you guys know all these things, but we're focusing on quality of life. Again, this improvement in quality of life through reduction of symptom burden for a patient leads to quality of life improvement for our caregivers as well. We know that we can provide interventions for patients at any stage of illness through any point of life and any age. So we're not limiting our ability to care for people just to a specific age group. or specific diagnoses. If you're pretty sick and it's pretty serious, we can help you. And so we want to see these folks. We can provide the care we give you in conjunction with any of the other treatments you're getting. I think a lot of times there's this misconception that if I have palliative care, I can't have chemo. So I tell patients, I'm just another member of your clinical and medical management team. This is my specialty. I offer these things as my way of contributing to improving your life, but your other specialists continue to be just as important in their own ways as well. And so we're not replacing anybody. We're just kind of bringing our services forward to add another layer of support. I think a lot of times we're much better trained in communication than a lot of different specialties. We have specialized training in communication. So really that's the intervention we offer. So when people talk about what procedures their specialty offers, our procedure is the art of communication. And so we come forward to patients, I think consistently along that trajectory of illness to say, tell me what you understand about what's going on right now. And how does that make you feel? And does that line up with what the goals are that you want for yourself? And so this assurance for goal concording care, I think remains kind of the undercurrent thematically of all the work we do for patients, that we are very committed to kind of say, what matters to you? What's important to you? How do we align care and the interventions we provide to you so that they're mindful of those things and they are in line with what you want for yourself? Care we give, which is slightly different than some other specialties, is that we're an interdisciplinary focus. So you may see the palliative medicine provider. You may also see a palliative medicine nurse or social worker. Sometimes a chaplain may be providing additional support. So there's multiple members of the team that are available to you and to your caregivers to help provide those layers of support. And again, the support is probably the one thing we can't underestimate. We can know from our data on various levels how important support is. And when you look at the literature for pulmonary disease in particular, you see a fair amount substantiating the need and the import of support for patients with advancing lung disease. And so one of my friends, Jennifer Wesco, started the Wesco Foundation for Pulmonary Fibrosis after her father died from that disease. And the organization is committed to connecting, patients to resources with pulmonary fibrosis. So there's a partnership with the Pulmonary Fibrosis Foundation. She does a ton of interconnected patient support groups at various institutions with advanced lung disease programs. And now because of COVID, she's kind of taken that virtually so that patients from all over Pennsylvania can connect with each other in these virtual platforms for ongoing support and resourcing. Some of the special challenges I think that are unique to our lung cancer populations in particular are that their symptom burden is really high. Lung cancer treatments can be really intensive, right? These patients can have any combination of surgery, radiation therapy, and chemotherapy. Sometimes it's concurrent chemo radiation, sometimes it's surgery followed by two of those things, or it's two of those things followed by surgery. And so the variability is tremendous. And anytime you put someone through a major intervention, they're going to have a higher symptom burden. So I think our opportunity to intervene and make adjustments to their medication management and treatment algorithms to help them feel better is really high. The opportunity is really high at these points. There's often really poor provider recognition. And why is that? Twofold. One is I think patients come into their oncology appointments and are really afraid to tell their oncologist, yeah, I don't feel that great, because maybe they'll stop my therapy. Maybe they're going to reduce my therapy and then I don't have a chance of getting cured from this or as better as I can. So they're very, very reluctant to kind of report those symptoms. When they come in to see us though, we're specifically there to treat their symptoms, right? So if you don't feel threatened that I'm going to take away your chemo or limit your radiation, but you know that I'm there to really treat your symptoms, get them under control, improve them so that you can continue to tolerate your other treatments, I think you're more likely to share with me what's bothering you today or what's getting in the way or what's been holding you back. Treatment decisions along the way are another piece. These patients need constant reevaluation of their goals. Do they want another round of chemo? Do they want to try another cycle? Is there more radiation? Would that be worth trying? Are there risks to any of those, that may be adverse or lead to an outcome potentially the patient doesn't want, or ultimately not get them to where they want, and so we help with those, I think, more nuanced conversations for these folks. When you kind of say, well, what has added to the anxiety of any advanced disease patient in the country today? I think COVID is the answer, right? Every single patient with an advanced illness, but particularly patients with advanced lung disease and lung cancer, have a magnified sense of anxiety and almost like a dread, panicky type sensation because of COVID, because it becomes such an all-inclusive fear. If I get COVID, I'm going to have to stop my chemo. If I get COVID, I can die quickly because I have impacted lung disease or some underlying lung failure. If I get it and my chemo stopped, my cancer might progress, and then maybe I'll survive the COVID, but I'll still die from my cancer, and what do I do then? So there's all this panic that's just swimming through their heads. And so I think sometimes giving them that safe space therapeutically to come and discuss these fears, or to potentially treat some of them if we can, is super helpful. And so what are the things you can try to do to kind of empower them again? And what are the things that are in their control? Are there other diseases we can help you manage? So can you get your anxiety and your depression under control? Is there insomnia now contributing? Because what happens when they're chronically sleep deprived, energy levels are low, quality of life goes down, the fatigue can affect their performance status. That may lead to then changes in their chemo and cancer-directed therapy regimen. So all these things just start snowballing for these folks. And so the goal is to just kind of intercede on all these levels whenever possible. I think we do a lot of good things, as you guys know, for lung cancer patients. They're all kind of outlined on the board, but reducing suffering is probably top of what we do. I think we prepare families really well. And again, I think it's the art of communication and what we bring forward to these folks that helps us do that. But I think it's very important that we say, here's the potential complications or the if-then scenarios. I'm a huge fan of the best case, worst case scenario model for discussion. And so a lot of times when patients are kind of hypothesizing and they're getting a little too extreme, I found it super helpful to kind of come back to, well, what's the best case scenario? What's the potential worst case scenario? And then really let's now talk about what I think might be the most likely scenario. And then how are we going to know which direction we're going towards? What are the markers that would indicate we're heading towards best case scenario? What are some indicators that might be that we're trending down maybe towards the worst case scenario? And then we'll reevaluate along those points, and we'll rediscuss what matters at each of those points as those things unfold. The advanced care planning piece, as you guys know, is tremendous. So we talk to them a lot about their goals of care. Do they have an advanced directive? I think a lot of systems, have a mechanism in place. And then a lot of us are kind of struggling to get a mechanism in place. And so one of the things we're working on now here at my organization is to get a system-wide initiative for advanced care planning to at least have a healthcare surrogate designated, so at the time of admission or prior to admission, so if you're coming in for surgery, to have this preemptively addressed, for example, in outpatient surgery clinic, that we know in advance that if things go wrong or something happens, or you're not able to talk to us, who's the person that we should be asking, to help make decisions for you? Who knows you best? Who have you talked to, or who do you feel, if you can't bring yourself to talk to them, would make the right decisions for you? And, over the years, I think I used to really get in the habit of saying, who's your closest family member, or who in your family should I update? And I have found that concept of family, in the last decade or so has really shifted for folks. And so now I have found myself, in an effort to be more mindful of being inclusive and, trying to address some of these disparities in care, to be a bit more broad and mindful of how I ask that question. And so now I ask the question, who in your adult life has been the greatest source of support to you? And is that someone you feel would be able to help us make decisions for you if you were in a situation where you couldn't? So I find that shifting that question has helped a lot, because especially in rural health, which is, we're extremely rural in this location, families are not necessarily direct relatives. Sometimes it's close personal friends or neighbors or, coworkers. I had a family meeting in our COVID ICU 2 days ago where the person's support that came in was his manager, from his workplace. And that was the person helping this individual's family make decisions, because that was someone that had been really close to this patient. And so, I think you just have to be able to kind of be willing to ask the question more broadly to get that information and kind of start piecing that together for them, and then documenting it and getting a form filled out. I think a lot of times it's really hard for people to fill out that form. It somehow signifies something's going to happen or something bad will happen. And so One of my partners in the advanced care initiatives is Dr. Ann Rizzo here, and she is a phenomenal trauma surgeon, ICU physician, and palliative physician, kind of all wrapped up into this one amazing package. And she and I have kind of both maintained, let's at least just know who you'd want us to call if something were to not go right or something complication happened unforeseen. And let's not worry about getting forms filled out right away. If you're not ready to do that, let's at least just get to know who your healthcare proxy or surrogate should be. And I think when you do all these things, you're supporting not just the patient's health and well-being, but then really also that of their caregiver, because they may be wondering the same things, or they need a door to open to kind of bring up these points in conversation. And so when you talk about how do you have a palliative care consult for lung cancer, we follow National Comprehensive Cancer Network guidelines. And then I take those core elements from the National Quality Forum as well. And I really look to see, what are their symptom assessment and treatment needs. I use an ESAS score. I use a palliative performance score. Some of these interventions we offer are medication-based, some are non-medication-based, and that's where pulmonary rehab, for example, comes in. We're talking about goals, we're talking about transition planning, they may be post-admission, and we're doing like a transitional care management type of visit. And then I look at the ASCO guidelines as well, which says, that the patients should have, any kind of advanced cancer patients should have palliative care services early in the course of their illness. And I think we'll get to that in upcoming slide, but really more specifically, patients diagnosed with an advanced cancer at diagnosis within the first 8 weeks should be seen by palliative care. And so I've been bringing this forward to most of our cancer boards. And because we report off on the quality reports once or twice a year with all of our cancer board meetings, I've now been bringing that forward as part of those presentations as well to kind of drive that point home that, there's formal recommendations from our national leadership organizations that we need to be implementing as part of routine care, routine practice for advanced cancer patients so that people don't slip through those cracks. Because I think, again, provider identification of where those needs are is lower than maybe what we can recognize them to be. So here's the ASCO guideline I was telling you about. So you want to have treatment, palliative care involvement, not treatment, within 8 weeks of that diagnosis. So metastatic lung, advanced breast cancer, et cetera. Patients with high symptom burdens should be automatically referred into us. If they're having trouble tolerating their therapies, getting through therapy, or starting to question, feeling conflicted about the side effects are so intense, I don't know if I want to keep going, but I don't want to die. How do you help people kind of get through those things? So I think these are all indicators for when you can get us in and to see these folks. And I think if one thing we've learned in the recent years through COVID is that certainly telemedicine support can be really helpful. Being in rural health now for the last 14 years, I can tell you that telemedicine was used at my prior health institution for years before I came here, and was supremely helpful in kind of bridging that gap for our rural health patients that can't get to the hospital or have limited transportation or don't have the means, frankly, to get, or for whom transportation services don't go out that far, right? So to get them to a telemedicine support profile was infinitely helpful. And a lot of times, we did it one of two ways. We can get you telemedicine visits from home, if you can use your tablet or your computer, but for our patients who did not have that capacity, most of the time, a primary care office was somewhere within proximal vicinity to their homes. And so they could go to that location and we would have a telemedicine visit from there. And so that really simplified the process for, probably close to about 80% of our patients who were having trouble getting to and from appointments for transportation reasons or just really lack of support. So I think telemedicine, is something we should all be comfortable leveraging to kind of help us bridge gaps for that. ASCO guidelines kind of really mainly concluded, don't wait to refer patients. I think this is something infinite. A lot of times you see that it's still the norm for oncologists, 68% in a recent study weren't referring patients that were appropriate. The ones who were sent in earlier, we know from the earlier studies, receive better care. People who have palliative care early in the intersection of advanced lung cancer, for example, actually lived longer than patients who didn't have palliative care, and that was side by side along standard oncologic management. So I think there's benefits to that. There's data now showing that, just kind of having to reiterate this, having to provide that education, and on some level, perhaps even bring it into a workflow. So we're actually looking now about bringing those processes, those trigger mechanisms into the workflow, both in Epic on the inpatient side and then in Beacon on our outpatient oncology navigator side. Caregivers can be referred to. I have found this sometimes gets a little sticky because whose chart do you put the note in becomes the issue. So I have often just kind of said, I'm going to put it in the patient's chart because this is the patient's caregiver coming to see me. And I just kind of structure my note to reflect that this individual is here to talk to me about stress related to caregiving for this patient. And then here are the issues that were discussed. I think our availability is things, we are a rare find as a specialty these days. And, pretty soon we may be very impossible to find because there's going to be a deficit of palliative care provider shortages coming up in the next 1 to 2 decades as people are retiring and not as many people are coming into the specialty. So I think, on one hand, there's a growing need, there's a growing recognition and growing appreciation, I would say, for palliative medicine interventions and care. On the other hand, there is a declining number of totally available providers. And so we're going to have, a deficit potential in the care delivery if we can't come up with some additional mechanisms. So, I think we can all agree, does our health system, on national scales meet these challenges? And I think we can kind of all say, no, I don't think we do that very well. And what are the reasons? We're a sick care technology system. We are very disease driven. We're just kind of looking at, you have this disease, we're going to treat this disease, and then we're going to send you home. And then we fail to kind of take in that comprehensive view of this patient. And in caring for a patient with any type of advanced cancer, caring for their caregiver is equally important because that's part of caring for the patient. And, I'm a huge fan of Ira Byock and the whole person care concept. And, I have often maintained the position that in caring for the whole person, our patient with cancer, we also have to remember that part of that whole person is their caregiver, their family. And so that care that we offer, that support that we offer needs to extend beyond just the person, with the disease itself. Most providers, apart from us, are not necessarily trained, in symptom management or in that communication about serious illness and kind of serious illness planning. There's certainly a huge fear of opioid prescribing. And there's a really restrictive mentality in the practice of a lot of non-palliative providers to offer opioids in any kind of ongoing chronic manner. And so I think these patients can often be shortchanged or even actually labeled, unnecessarily as drug seeking when in fact they have true symptoms that need to be managed and are poorly managed. Very recently saw a patient, I'm following now for severe pain, has had chronic spine related pain from numerous prior work injuries. And, because he couldn't get good pain management help over the last 20 years, took to drinking. So for 2+ decades, he's been steadily increasing his alcohol consumption as his pain management. As a result, had not been able to work. You have to really wonder if I'd had this opportunity or someone had helped him with his pain management even 10 years ago, is this the type of thing that maybe we wouldn't be looking at today? And potentially, I don't know, maybe what could have still happened, honestly, but there's always that potential that this poor guy had this degenerating, painful condition and nobody was really able to intervene. And so he felt his only option was to self-medicate, with alcohol, which created this rippling effect of distress, on his family, on his children, on his spouse. And so I think, what are the other ways we can intervene? We need to do better, I think, about any of these things that our patients and our families are facing. And so the first step is at least to kind of be getting involved at the right time or as earlier as possible in the care of these patients. And so when you think, what do you want when there's serious illness? What do we want for ourselves? What should we want for our patients? You want to achieve a cure or keep the cancer in check. I tell a lot of patients today, they hear from prior discussions, well, this cancer is not curable, and they just get so downtrodden over that. And it's like, well, listen, let's rephrase that a little. Is it not curable and it's deemed terminal? Well, no, they didn't say that. Okay, so what they're saying that it's potentially controllable. So I encourage patients today to really think of cancer as a chronic disease. So we're going to manage it in a chronic and ongoing manner, just like maybe we would have managed hypertension for you or diabetes for you. It's going to be a chronic disease. There's going to be points along the way it may worsen. There's going to be points along the way you may have exacerbations from it, but we're going to continue these interventions to try and keep it in check and control it for you or slow its progression, which frankly is the same philosophy we use when we're managing things like smoking related COPD or pulmonary fibrosis or cystic fibrosis. All of the interventions we're doing are meant to try and slow down the destructive process of advancing lung disease and help maintain a patient's quality of life, functional independence, and performance status for as long as we possibly can. And that kind of requires a lot of coordination of care and support, to help people make these really informed decisions. And so think about the untreated cost of suffering. And that patient I gave you is a great example, but the quality of life that it has, the impact that it has on their families. They can't adhere to a treatment plan if they can't get the medicines or the care they need. And maybe these people, because they don't know how to access that care, have increased utilization of the emergency room. That becomes their primary care office or hospitalizations. So when you think about the lung cancer patient, that kind of shifts you into how does pulmonary rehab help these patients really specifically. So the first thing is to kind of explain what is pulmonary rehab. It's a structured program, usually led by a respiratory therapist with medical oversight from physicians. And it's exercise training, education, behavioral change. It's really tailored to each patient. So their intake kind of determines what their plan is going to be. It's designed to improve both physical and psychological conditioning for patients with advanced lung disease and lung cancer. And it kind of helps them get a plan they can continue on after they complete the rehabilitation program. Most pulmonary rehab programs are a 12 to 16 week long program. And it's usually anywhere from 1 to 3 visits per week that they kind of schedule out with patients based on, what's the patient's willingness and ability to come to those appointments, as well as what was the approval and prior authorization given by their insurance companies, and what's their ability to tolerate therapy. How often can we do that for them? It's in addition to medical management. So lung cancer patients who are getting pulmonary rehab don't give up their cancer therapies, much like when you see palliative medicine, you don't give up your cancer therapy. So this is another layer of medical intervention and support that we're giving our patients. And then the effectiveness of those has really been demonstrated nicely in multiple research studies. So it's a comprehensive program. It's the art and the skill of clinical care, physiologic management, behavioral tools. The behavioral tools that people speak of are things like, if they're still smoking, we work on smoking cessation. If it's physiologic dyspnea, for example, we're doing dyspnea management. We're doing energy conservation maneuvers. We're teaching people how to group certain activities together so they're not as exerted prior or after doing those things. Learning how to adjust to their life and how to tolerate different activities. So what is one thing that an advanced lung patient will always tell you? What do they dread? They hate the stairs. They positively hate the stairs. Sometimes though, climbing steps is inevitable just because of where they might be. There's no elevator, ramp, etc. And so one of the things you learn in pulmonary rehab is, one of the ways you can tolerate taking the stairs better is to actually exhale on the step up. So they can stop in between, but if they're exhaling on the step up, they actually get less breathless. So it's a technique, and these are the types of techniques you're teaching them. And the energy conservation stuff is like, maybe you have to group certain activities together in the morning so that you don't get as breathless, doing too much at once. And so it might be when you first wake up, have your nebulizer on the nightstand so you can do a nebulizer treatment and get that out of the way before you begin other things, and then if you're going to go for your next step into the bathroom for bathing and stuff like that, maybe we get you a shower chair so that, and a handheld shower rinse, so it's easier for you to do those activities. And so you're just trying to kind of get people to a place where they can tolerate these things better. The aim is to really rebuild their functional capacity. The exercise program that pulmonary rehab offers is a graduated conditioning program. So even for the patients, for example, who are not quite sick enough to go to pulmonary rehab, like my advanced lung patients, I think right on the brink, they're not appropriate for pulmonary rehab just yet. You start them all off on really slow, gradual conditioning programs. So, and this works for cancer-related fatigue as well, but if they have a treadmill or an exercise bike or a Wii or whatever it is they're using, I ask them to do like 3 to 5 minutes, 2 to 3 times a day as a starting place. When that starts to feel easy, I ask them to go up in increments of 3 to 5 minutes till they get to a space where they're able to do, about 60 minutes total of exercise per day. And I don't care how they break it up. I ultimately would like to say that we can do 60 minutes at once would be great, but that's not always possible for every patient. So if they get to a place where they can do 15, 20 minutes at a time, but three times a day, equally accessible. Another thing we've used a lot in pulmonary medicine are like the foot pedaling devices. So you can get these at Walmart for like $25, $30. Even if they're seated at the table, they can pedal with their legs. That increases some conditioning and strength. But then you can bring it up on the table and they can pedal with their arms, and you just turn up the resistance a little bit. And again, that improves their conditioning. And then overall, what happens when you improve their conditioning? Their muscles are strengthened. What happens when you strengthen a muscle? It uses oxygen more efficiently. What happens when you use oxygen more efficiently? You're less short of breath. So there's just that physiologic response that you start seeing in these patients as a result of these interventions. So we talked about some of this in my previous chatter, but we're improving their breathlessness. We're improving their ability to tolerate activities. They can eat and drink more. Oftentimes their appetite will improve. We also provide nutrition support in pulmonary rehab. And so they would meet with their nutritionist. If they need weight loss, they also meet with a dietitian. So, both are offered. It decreases their hospitalizations and utilization of the emergency room because they are also taught early monitoring signs, how to intervene, what to do if you've noticed like peak flows are changing or changes in, what are the signs of COPD? Your mucus is changing color, your cough has increased, you're more breathless, and so they kind of have things to monitor so they know how to do that. And increasing their strength improves their ability to tolerate disease-directed therapy. So again, if you're feeling stronger, you tolerate your chemo better, you're not as washed out or as deconditioned by the effects of that therapy. And so you're a little bit more resilient in your capacity to tolerate it. But I think that most importantly, it gives people that sense of empowerment and control back because they can self-monitor, they can assess their own progress, they can identify their needs earlier if something's changing, or frankly, if something's getting better, and they feel more empowered and better about themselves. And when that happens, their mood increases. And, when they're less depressed, their caregivers are less depressed because again, things at home on the overall are better. So some of the things I say, the tools of pulmonary rehab, addressing these underlying pulmonary issues is great. They have the exercises like I outlined about upper and lower extremity. Breathing retraining is a huge thing. Airway clearance, again, it's a huge thing. So are these folks using a flutter? Are they doing deep breathing? Are they positioning? Do they need some chest PT? Can we teach your caregiver how to do some simple chest PT, if the flutter is not your thing? If you're bronchitic enough, would you qualify for a vest? The respiratory therapist at pulmonary rehab will determine that. And frankly, if they feel you qualified, they'll get the ball rolling on the paperwork necessary to get you qualified for a vest. Now, I don't know if any of you have ever tried on a percussion vest, but in my old practice, which again was pulmonary critical care, at one point I had a very wicked pneumonia. And you get over the pneumonia, but that cough and congestion just lasts forever. And I came into work just sounding really bronchitic and very congested. And the respiratory therapist just marched in and said, we're going to put this percussion vest on you because I think you need to really get some of that broken up. And so she set up an albuterol nebulizer, slapped on this percussion vest. And, the first couple of hours, I was like, does this thing even work? Because I'm like really not coughing a whole lot. About 3 hours later, when I was home, I coughed all night and brought up so much junk. And I have to admit that the next day while I was tired, my breathing was significantly better because I had just coughed up so much junk. So it's impressive how just that little intervention just for me with no lung disease led to such substantial relief. It makes you think, how effective could it be for someone whose disease burden is higher and whose symptom burden is higher? So their relief might be more magnified. Bronchodilator optimization is a big thing, the self-management piece. But I think most of all, problem solving, teaching people how to solve some of these roadblocks and how to kind of work towards optimizing their care is empowering. And so the more we can do that for people, again, the better their quality of life gets. How do you get them into pulmonary rehab? It's relatively straightforward. You can refer them into a pulmonary rehab program. These programs become, customized for a patient after their initial assessment. So you have to refer them into the program. They'll be scheduled for an intake visit. And then their program itself will kind of be outlined for them after that assessment. Where is it done? Variety of settings, hospitals, pulmonary rehab centers, and now via, telemedicine and at home because of the circumstances now of COVID and the needs for spacing and limited number volume of patients in the organizations. So we have this capacity now to kind of deliver this care across all of these spectrums. So some of those key takeaways, I think, from overall, lung cancer, pulmonary rehab, and palliative medicine, and how we kind of all intersect. Patients are living longer than ever with serious illness. So things like lung cancer will benefit from interventions like pulmonary rehab, because it's teaching people better ways to manage their symptoms and live with their disease. And ultimately, again, it's an intervention we're offering them. Patients have complex symptoms that often are not being managed. So escalating to specialists like us, I think, helps them feel better. And that should just become normalized into care. It should not be this exception. It should not be like, oh, I think they're going to die in a couple of weeks, we're going to send them to palliative care. I think it should just be, you have an advanced cancer, palliative care is a routine part of managing advanced cancer. And so we're going to we would send anybody to palliative care with this situation. So this is a normal part of what we offer as comprehensive cancer services. The cancer and the symptoms, I always argue, should both be treated. It shouldn't just be that we treat your cancer. It shouldn't just be that we treat your symptoms. You can have both. That doesn't have to be an exclusive situation. Pulmonary rehab, as I've shared with you, is a really excellent way to help these patients improve symptom control, reduce their symptom burden, improve their conditioning, and really be able to tolerate their therapies better. But most importantly, it puts a sense of control and power back into these patients' hands as they start to see the benefits of pulmonary rehab. And so it is, something you got to stick with for a little bit, but you start to see the effects of it. And I think that patients and families should ask for palliative care, if they're struggling. And so I always try to have our brochures in some of our key clinics. So our pulmonary clinic, our heart failure clinic, internal medicine and family medicine all have palliative care brochures. I work with our ambulatory care management group with ongoing education so that when they're seeing these patients at their transitional care management post-admission chronic disease visits in the clinic, they're able to kind of say, I think palliative medicine might be something that could benefit you. On the hospital side, I've been piloting since I got here for about 2.5 years, an acuity tool. So I get a report every morning that kind of has a summary of all the existing inpatients and then several metrics that we follow. So there's a total of 9 triggers that I've kind of identified using some of our national data of who should be seen in a hospital setting. Patients who score 6 or higher on that scale, we have found that would benefit from palliative care consultation. And we chose 6 because initially I chose 4 and I was capturing way too many patients. And when you start reviewing those charts, really not all of them, qualified. 5 was better, but we were still catching a fair amount, for example, of the bariatric surgery population because the albumins are low and the renal function was a little impaired sometimes, and so that would keep triggering. And so we moved it to 6 and have found that we're really capturing higher acuity, our ICU patients, our advanced disease, chronic illness patients, so heart failure, lung failure, renal failure, liver failure. And so we're just kind of trending that out now and following the data to see, does this remain consistent? And so now we're studying what percentage of those patients that are flagging positive are we actually seeing on a consistent basis. So we look at that kind of monthly to see where we're trending. So these are some resources on pulmonary rehab. Thoracic.org is the American Thoracic Society's website that has patient resources that you can print out and give to your patients. So it's kind of just all nicely streamlined and compiled. The last thing, though, that I wanted to point out is probably what's been the most helpful, the COPD Foundation's Pocket Consultant app. It's free. It's a free download on both Android and iOS. And this gives patients and families not just information about COPD, but it also gives them like exercises they could do at home. It has little snippets of videos and it's a free app. And so it's, vetted through the COPD Foundation. It makes it very easy for patients to monitor their symptoms. They can have a daily, symptom tracker in there. And so I think that helps contribute to them, again, taking some ownership and some control of their disease and their symptom management. So those are some of my resources or references, from my lecture today. And I'm happy to send those out to anyone if they want to read them in more detail. And then I'll just kind of end it here and say, in anticipation of the upcoming holidays, I hope everyone has a very safe and happy holiday season. And I'm happy to take any questions.
Hi, Patty. This is Sandy Moshka. I'm an advanced practice nurse at St. Luke's in Milwaukee. Been in palliative care for a long time with my focus on outpatient cancer patients. Thank you so much. I have to say, I'm a little embarrassed to say I've never, ever even thought about pulmonary rehab for my patients. I don't even know if our system has an outpatient palliative or pulmonary rehab. So I've already sent out an email to the team to see if we do. because it's amazing. I can't wait to see if we have one, or maybe Katrina, we can have a project to work on in the future. Thank you, Patty.
Yeah, thank you.
And Patty, I wanted to thank you as well. I appreciate the reminder of maintaining hope when you're talking to patients with cancer that's not curable, but recognizing that I think the emotion that we set in the room matters so much. I think patients feed off of our presentation.
Absolutely. I think that tone is so important. I always try to remind the residents that you don't have to go in, like being so dire. It's okay to go in and be hopeful, and it's okay to, to kind of share their worries and share their fears and say, I worry about that too. And let's just see what unfolds. But, the one thing I have found in the last 2 years with COVID particularly is there's just so many unknown variables with it, and things are just changing all the time, that frankly, best case, worst case scenario approach has just worked best for me. And I think because we're using it so much more in that vein, I found myself starting to use it more, in non-COVID discussions, and really found that to be a better meeting place, for patients, their families, and the medical teams. So.
Yeah, agree. Right. All right. Thank you, Patty. I think we will wrap it up for today. We really appreciate you joining us today.
Thank you, everyone. Have a very Merry Christmas.
You too. Take care.